This is an image of a voiding cystogram. What is this?
Bladder?
It's not a baby's rattle. So this is the bladder. This is the bladder, okay? So we're seeing the bladder over here. We've got this one vessel coming down.
It's a ureter?
Ureter, and it's going to make its way down into the back of the bladder. What is this junction called?
The ureter
Uterovesical. Okay, UV junction is right there. Okay. What is the smooth muscle in the bladder called, where this ureter enters?
Trigone?
Trigone. Okay, it's got that. It's a trigone. Okay, so it's a trigone. What is this area right here?
Urethra?
Okay. Do we agree this is the urethra?
Mm-hmm.
Okay, so this is the urethra, male or female?
Male.
Is it male?
Yeah.
It's male.
Looks pretty long.
Urethra. That's a pretty long urethra,
Yeah.
right? So this is male. Can we also determine the age of this male?
It's a kid.
It's a kid. How do we know?
The growth plates are right there.
Ah, so you guys are, yeah, you know your stuff now. Look at this. So growth plate there. Look what's happening here. That hasn't even formed yet. See that?
Mm-hmm.
The obturator foramen. So you've got that area between, what is it, the ischium and the pubic. They haven't even formed yet. Ischium and ilium, I should say. Sorry. All right. All right. So let's talk about now the procedures that are done on the urinary system. So urography is the generic name. It's a generic name of the study. This is a radiographic examination of the urinary system. We are going to be using water-soluble iodinated contrast. Depending on the doctor, policies of your hospital, you can be using either ionic or non-ionic. Okay? Most places now, they're using non-ionic because it's a little bit safer, but you still have hospitals using ionic forms of iodinated contrast. It is injected intravenously or through a catheter. This will be you guys performing these type of procedures. Have you guys seen an IVU or an IVP in your department yet?
Mm-hmm.
I saw a VCUG.
A VCUG, okay, but that's going through the bladder.
Yeah.
Okay, has anybody seen an intravenous type of procedure with injected contrast? Okay, you'll be seeing a lot of this in CT, and hospitals are getting back now into doing these procedures in the radiology department. What happened for a long time was that we did these studies and then it went away and it went to CT because CT was a little bit more diagnostic. You can see it a little bit more. But what they also found out was the patient was getting unnecessary radiation exposure because CT produces a lot of x-rays. Okay, so they took it away from diagnostic radiology, put it into CT, and now it's making its way back into the radiology department again. So now you're going to be seeing an increase of technologists performing these IVUs, which stands for intravenous urogram, or IVP, which stands for intravenous pyelogram. IVU or IVP. Okay. So the contrast, this is going to be all review because we've already talked about this. So when you use ionic contrast, it's going to be more risk of a reaction. Any of this contrast should be put in a warmer. Have you guys seen a warmer in your department yet where a contrast is kept? Okay. Well, there you have what's called a warmer. It's a box that heats up the contrast into body temperature so that when you do inject the contrast, it's a little bit more forgiving and less painful. And what they also said is that it reduces the chance of a reaction due to the warmth of the contrast. I don't know how that works, but they say it does. The other thing too, the second part of having this box is that it keeps it in a dark environment, because when you leave iodinated contrast under light, whether it's natural or artificial for a long period of time, the efficacy of the molecules starts to break down. So it's not going to be as effective when injecting the contrast in the system. They actually start to get a little bit diluted. Okay, so the box keeps it warm. It also keeps it away from the light. Okay, these are the new numbers. These were taken from your other presentation, so you need to change these. Okay, because on your slides you just given one number, right? Here I'm giving you guys the range. So ionic has the osmolality of 1,200 to 2,000 milliosmoles per kilogram. In general, what are we talking about here? Osmolality.
Viscosity?
Viscosity, the thickness of it, right? And because of that viscosity, it can determine the shift of the interstitial fluids into the vessels. So ionic, very thick. Non-ionic, 291 to 702. Okay, very close to the osmolality of blood. So this is why this is the better way to go is the non-ionic. Everybody got the numbers? All right. So low osmolality is what we prefer. However, the problem here is that it can be more expensive than the ionic, sometimes up to 6 times more. And with the non-ionic, there is a less chance of a reaction. But again, this is what they have to deal with. Okay? Do we want to pay more for it? Or do we just, buy the ionic, pre-medicate our patient, and we can get away with it that way? Also, visually, what's going to give you a better study?
Ionic.
Ionic, right? Much thicker, more iodine. And again, I think I told you this before. The whole thing about using non-ionic is it's better for the patient, but the doctors usually end up injecting more because they can't see the vessels. Okay, side effects versus a reaction. The side effect is an unexpected outcome to injected contrast media. The common side effects includes a temporary hot flash, a metallic taste in the mouth, a warm feeling throughout the body, maybe a warm feeling on the injection site. Those are all normal. What is that called?
Transient.
Okay, very good. Okay, so a reaction is an unexpected outcome to the injected contrast media. Okay. A reaction is an unexpected outcome to an injected media. The vasomotor effect is a non-allergic reaction often based on fear or anxiety, usually non-threatening conditions. So this vasomotor effect is caused again by nerves, okay, not knowing what's going to happen, so it's fear of the unexpected. It can also be a response to the pain as you're being stuck with a needle. Okay, okay. So this may be caused by anxiety. It may cause anxiety, lightheadedness, some nausea, syncopal, and also mild urticaria. Now, when we say nausea, what do you guys think when you hear nausea? Okay, okay.
Queasy.
Okay. So basically what nausea is, sometimes you relate it with vomiting, so it's like the urge to vomit. But the general term for nausea, just so we're all on the same page, when you feel nauseous, it's the uneasiness of your abdomen. Sometimes accompanied by, bless you, sometimes accompanied with the urge to want to vomit. Okay, but nausea is a general discomfort or uneasiness of your abdomen. Okay, and then mild urticaria. Anaphylactic reaction is a true allergic reaction that may lead to life-threatening conditions. But we've already talked about what iodine really is, right? Is it a true anaphylactic reaction?
Mm-mm.
It's what?
Anaphylactoid.
Anaphylactoid. Okay? So that's why contrast agents are so dangerous, because there might be a response, there may not be a response. The contrast agent kicks up these different sensors that activates the histamines and the complements. So they may happen one time, it may not happen the next. And that's why contrast is such an unpredictable thing. And you should always treat every patient as if what?
They have infectious
They're
disease.
going to have a reaction. So always be prepared.
Oh.
Sorry, Mom.
Yeah, that
Always
one.
be what?
Gross. But
Oh.
sorry, Mom.
Yeah, gross.
That's what I said.
That makes a good shirt. You guys don't want to make a shirt like that? You guys remember the Garbage Pail Kids?
Yeah.
Yeah, so yeah, that
That's
would
your-
be a good.
that's your average
picture to
patient.
put on your, yeah, your motto.
Feeding
All right,
garbage
so
pail
symptoms
kid.
includes moderate to severe urticaria, laryngospasm. So remember the histamines and the complements acts on the smooth muscles. So you feel again a nausea, sometimes a real heavy cramping. It also acts on the smooth muscles of your respiratory system, so that'll also clamp up, causing difficulty in breathing. Some swelling around the face, that's angioedema. Hypotension, what's hypotension?
Low blood
Low
pressure.
blood pressure will call, and also tachycardia. See how that kind of, remember, naturally your body's going to want to balance itself, okay? So if hypotension, your blood pressure is going down, it's going to increase your heart rate. That's naturally what should happen. But can you also have hypertension with tachycardia?
Mhm.
Yeah, but that's not normal, and that's what we need to address. Okay, when something like that happens, but normally your body wants to adjust itself, so if one goes up, the other one goes down, and then vice versa. All right. Vasovagal reaction. A vasovagal reaction is, what does it say here? Contrast agent stimulates a vagus nerve, a life-threatening condition, which causes you to drop your pressure, slow down your heart, no detectable pulse. That's especially if you don't have a detectable pulse.
That's bad.
That is bad. Okay,
You're
that
dead.
is bad. Okay, because you may have a pulse. I mean, electrically you may have rhythm going on, but if it's pulseless, okay, that's when you gotta intervene. Hi.
Sorry.
Okay. All right. So these are life-threatening conditions, and you need to respond and react quickly and actively. All right. Acute renal failure, where the kidney shut down. Some symptoms of renal failure includes diminished urine output and also anuria. Anuria. Okay, reactions to contrast media. First one is mild reaction, which includes nausea, vomiting, some minor hives, itching, sneezing, extravasation. Okay, remember what we said about extravasation? And then the vasomotor response. Now, vasomotor response, that was referring to what?
Fear.
Okay, that's kind of the transient response, okay? It comes and it goes. All right. Anytime that you have a response, regardless of how small it is, you need, bless you, you need to be ready for action, okay? And these aren't things that need to be taken lightly. So if your patient is experiencing, even if they start to sneeze, if they cough and they're saying, ooh, I'm itchy, okay, stop what you're doing. You guys remember the list of things that we need to do?
Mhm.
Stop what we're doing.
Call
Okay,
for
stop
help.
what you're doing.
Call for help.
Call for help. Be ready to
Into it.
assist.
Take
Okay,
vitals
be
every-
ready to assist means know where the crash cart is, know where the medications are. You may be assisting in O2 therapy, some kind of medicine, medicinal therapy. Okay, but be ready to assist. But most of all, be ready to perform what? CPR. Okay. Never ever leave your patients alone. Take vitals every 5 minutes. Do you guys have a test on that today? Or was that last week?
That was last week.
Previous week. What are we having a test on today?
Infectious agents.
Oh, infection control. Okay. I still have the right to test. I have to put it together. Just kidding. It's already put together. Okay. Moderate reactions, okay, includes excessive urticaria, tachycardia, giant hives, and excessive vomiting. All right. So if a patient has a reaction, go back, let's go back over here. You need to document this, right? You have this? Okay. Good. Okay, you need to document this, okay. So document any type of reactions. So that way, if the patient does come into the department again for another iodinated type of procedure, it's there. You can check to see what happened, how they responded, what was the intervention that you did or the doctor did during the reaction, okay? as part of the history taking, you should be doing a few things also, is that you're going to have your contrast and your supplies to do the venipuncture. One thing that you need to do with the contrast is you need to check that you're using the correct contrast, okay? Because they do come in different viscosities. And each viscosity is applied to different specific type of procedures, so you want to make sure that you've got the correct one. So you want to make sure you've got the correct contrast. What else are we checking for? Date, expiration, what else? Lot number. Okay, lot number. So you also got to look at the lot number, where it was manufactured. And all this needs to be jotted down on the patient's chart or history form, okay? You should also be doing a visual check of your contrast. So hold it up to the light. Because if you see anything floating, is that good?
Mm-hmm.
Well, it's not expired. Can we use it?
Nope.
Okay, you still can't use it. So you don't want anything floating around, okay, in the contrast agent. So you also got to do a visual check. Minimum times of checking the contrast bottle is how many times? 3 times. A minimum of 3 times. You got to write that down. Minimum of 3 times. All right. Severe reaction. This requires immediate treatment, including very low blood pressure, cardiac and or respiratory arrest, loss of consciousness, convulsions, laryngeal edema, cyanosis, difficulty in breathing, and also profound shock. Okay. All right, so let's talk about the procedures. Routines may vary depending on departmental protocol. Did you guys talk about tomography?
One of my,
Please. Did you guys talk about tomography?
like the old school way of doing the slices,
Yeah.
or
Actually,
the
two, moving from one into the other. Did Miss Smith discuss that? Okay. All
they
right.
don't. It's the early days of CT. Before CT, right? It would take tomographs with the X-ray tube.
Right, right. Okay. All right, so I'm going to have to give you guys a brief rundown on how tomography works.
You sound like us.
What's the funny? What? The picture or me?
You.
Why?
Because you're just so disgusted.
No, I'm stressed.
Oh,
I'm stressed, yeah, because usually I just, if Ms. Smith had already discussed this with you, I just kind of zip right through the presentation. But now I got to talk about the physics of
We're
how
just getting
tomography
you.
works. She did? Okay.
Yeah, she did.
Shut up.
Yeah.
Really? Okay. All right. All right. So you'll hear the terms IVP and IVU. Sometimes they're used interchangeably, but the correct term is IVU, which stands for intravenous urogram. The other term that we use is IVP, which stands for intravenous pyelogram. But we're not looking only at the pelvis, we're looking at the entire urinary system. So this is the better terminology that we use, okay? So intravenous urogram, or IVU, is a radiographic examination of the urinary system. The purpose of an IVU is twofold. The first one is visualize the collecting portion of the urinary system. And number 2, to assess the functional ability of the kidneys. Just like the small bowel follow-through, we also have timed images in an IVU. So you have to keep very close track of the time of injection, because that will determine what time to take those radiographs. And there's going to be a series of them, just like in the small bowel. Okay, contraindications first before we begin. So when you're going through your patient history, you're asking them all these different questions. Some things that you might be also asking them is, do you have any allergies, right? Do you have any allergies to food or medication? Write it down. Do you have asthma? Write it down. Do you have hay fever? Write it down. Okay? Because each of those things will increase the risk of that individual having hypersensitivity to the contrast agent you're going to be giving them. So these are all different types of contraindications. So hypersensitivity, diabetes. Okay, someone who has diabetes is a good indicator that that individual has renal dysfunction. Okay, remember the contrast is thick. So if we introduce contrast into their system, their kidneys are going to work a lot harder to eliminate it, which can send them into renal failure. If they're in renal failure, and you're giving them contrast, okay, now they can't eliminate the contrast, increasing the chances of some kind of response or reaction to that. Okay. Can we still do this procedure with someone who's on dialysis, who has renal failure?
Oh, they already have renal failure.
If they have renal failure and they're on dialysis, we can do it because the dialysis machine is going to
They're
get
gonna
rid of
flush it out.
Yeah. Okay, so you still can't do it, even if their kidneys aren't working, but you have to make sure that the patient is on dialysis and they're scheduled for a dialysis after the procedure. That's another thing that you need to find out. If they are on dialysis, you need to find out when they're having dialysis done. Okay? You guys hear that? Because we want to get rid of it right away. If they're not scheduled for dialysis, we can't do this.
So they have to be having dialysis day of?
The day of. Okay? And if not, we can schedule it for them. We can schedule it for them. Not, well, the department can. You don't. Okay. Asthma or other respiratory conditions may induce exacerbated bronchospasms. Multiple myeloma may indicate, this is another one, may indicate renal dysfunction. Severe dehydration may cause major osmotic shifts and impair blood flow. And then again, if you have any type of chronic or acute renal or hepatic disease. Again, if you have hepatic disease, okay, what are those two things that we check for in our laboratory?
The bun and the creatinine.
Yeah, okay, the BUN and creatinine. So the BUN and creatinine will also tell us if they have hepatic disease. And if that's the case, then there's a great chance they may have renal disease too. Okay. Individuals with very poor cardiac function or acute hepatic compromise have increased lactate production or impaired lactic breakdown and also a risk of developing lactic acidosis. In other words, your body goes into, what do you call it, muscle cramping. Muscle cramping is caused by your muscles not receiving enough oxygen. So now just imagine that systemically. If your body's producing lactic acidosis, your body is not going to be assimilating or using oxygen very well. So this is what happens. And another reason why we need to check whether or not they have hepatic disease. Okay, other contraindications, anuria. If they're not producing pee, there's probably something wrong with their kidneys, right? Severe hepatic or renal disease, congestive heart failure, pheochromocytoma, rare tumor of kidney, anything that has to do with the kidney, these are all contraindications. Sickle cell anemia can compromise the function of kidneys, may cause red blood atrophy, and increase risk of sickle cell crisis or reduced blood flow. One of the questions you're going to ask your patients before you have this procedure done, are you on glucophage or metformin? This is an important question you need to ask your question. Are you on glucophage or metformin? Okay, this is a medication that diabetics use. It's a medication that diabetics use to control their blood sugar level. Okay. If they're on glucophage or metformin, they need to withhold at least 48 hours before the contrast is eliminated. Contrast can slow the elimination of metformin and can be toxic to the body, causing lactic acidosis and cause renal failure. Okay? So check on the protocol of your hospital. Some hospitals just say withhold 48 hours prior to the procedure. Some hospitals say we're going to withhold metformin 48 hours before and 48 hours after. So again, it depends on your department policy, but be familiar with your department policy. Okay, clinical indications for an IVU. Number one is an abdominal or pelvic mass. An abdominal or pelvic mass. Stones in the kidneys or in the urethra. Trauma to the kidney. Back pain. Hematuria. What's that? Okay, blood in the urine. Hypertension. Hypertension is a good indication to have the study done because if you have a stenosis in your renal artery, it jacks up your blood pressure. It jacks up your blood pressure. So stones in the, sorry, not stones, but blockage in the artery can cause hypertension. Renal failure, and then UTI, or pyelonephritis. You guys see this image right here? See this right here?
That's a stone.
Yeah, that's a stone. Look at what's going
That,
on here. Yeah.
that's the ureter. That's
so
all.
You've got some hydronephrosis, but you've got that stone sitting in there. The whole ureter here is also dilated.
Jeez.
So this is what it's supposed to look like. This is normal. See, nice and thin. Okay, here, huge stone. It looks like there is a stone there, but there is some urine passage, going through and making its way down. Do you think prep is necessary to do an IVU or an IVP?
As far as being NPO or whatnot.
Yeah, well, being NPO. You guys remember the VE prep? What do we got going on here? It's lying in the same area as what? Yeah, all your
So it doesn't-
all your junk.
So it has to be
It's
NPO.
right there, right where your small bowel is and your large bowel is. So we want the patient empty. Otherwise, fecal material can show up as pathologies in your urinary system. So they gotta follow the same protocol as a barium enema.
So then we do a scout. We do a
Yeah, so
KUB.
we're also going to do a scout, so I'm going to get to that there in just a little bit. Yes, very good. Okay, some other indications includes BPH, or benign prostatic hyperplasia. Simply put, enlarged prostate. Congenital anomalies, including duplication of ureter or renal pelvis, ectopic kidney, horseshoe kidney, malrotation, cystitis, UTI, glomerulonephritis, okay, inflammation of the loops of the glomerulus, and then polycystic kidney disease. Okay, so these are all indications. Oh, more indications, okay. Let's
Yes.
keep on going, okay. Cancer, renal cell carcinoma, hydronephrosis, pyelonephrosis, renal hypertension. So again,
Oh my
renal
God, there's
hypertension
4
is
pages
caused-
of these things.
I'm sorry, is increased by blood pressure in the renal artery due to atherosclerosis or even a blockage. Renal obstruction, vesicorectal fistula. It's an artificial opening between the bladder and any part of the colon. You guys remember the images, how close the bladder was to the rectum? Okay. So we may be doing it for that as well.
And it goes on.
Is that
No, there's one more or two after this.
Really?
Yeah.
Okay. Miscellaneous terms. Bacteriuria. Bacteria in the urine. Wow, Latin is just crazy. Why can't you say bacteria in the urine? Okay, diuretic. But it's less syllables. Diuretic, agent that increases urine output. Fecal urea. Glucosuria. Hematuria. Lasix.
A diuretic.
It's a diuretic. Lasix is given, it's
Oh my
a
God.
type of medication that's given to the individual to produce more pee. Yeah.
Cuts down the.
So fecal urea is perforation.
Say that again?
Sorry.
No, no, what?
Fecal urea, that's like, you need to perforate both the colon and the
Yeah, so
ureter
again,
for
we're
that?
going back to the vesico-uretal, so there's a communication between that.
Oh.
So that's when probably some fecal material is entering the urine. So if you're peeing,
Peeing shit.
peeing, fecal material, that's not a really good thing. Yeah, no bueno. Okay, lithotripsy, a procedure that is done in breaking down the kidneys and stones. Stones. Let's fix that.
That's a gnarly stone.
Yeah. Okay, so breaking down kidney stones by sound waves. So you get put in a large bucket, right? A large tub, and sound waves are produced to break down the stones. Nephroptosis, again, that's a drooping of the ureters and can cause a twisting of the kidneys, of the ureters. Oliguria is decreased urine output. Oliguria? Oliguria. Pneumouria, error in urine due to a fistula also in the colon.
So you're
Okay.
farting out your you're farting out your urethra.
You know, Eric, 'cause, I mean, not